So as a nurse at the bedside, you guys know that RTs are many different places. They're not just there. You guys are the first line of defense. You guys are the most important piece to being able to identify patients that are deteriorating quicker than that RT can if they're not at the bedside. So if you're able to understand that, that is so huge.
Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life. Welcome back to the Rapid Response Run podcast. Today we're diving deep into one of the most challenging syndromes we manage in critical care, and that is acute respiratory distress syndrome, or ARDS, or ARDS. And joining me for this follow episode is one of your favorite guests, my friend Melody Bishop. She is an RT. So Melody, welcome back to the podcast. So good to have you.
Well, thanks for having me back. I love talking about ARDS, so I cannot wait for this.
I figured you would. I figured it's kind of your jam to nerd out on this one. In case you missed episode 152, Melody's a respiratory therapist who loves nerding out on the pathophysiology as much as I do. If you haven't listened to our last episode together, go ahead and pause this one and go back and listen to our respiratory myth-busting episode, because it's a great primer for this deeper dive into ARDS. But if you have already listened to our last interdisciplinary collaboration, you know that Melody brings equal parts wisdom, clarity, and real-world practicality. She's awesome at analogies. So let's get into the pathophysiology, the ventilator strategies, and the evidence-based decisions that help us actually protect the lung instead of hurting it. Okay, so to begin, Melody, can you walk us through the pathophysiology of ARDS in a way that helps us see what's happening at the alveolar level? Like what's going on with surfactant, permeability, and the whole inflammatory cascade?
Yeah, and I probably won't get too much in the weeds here. I'll try to just simplify this as much as I can. So when you think about ARDS, essentially what's happened is some type of injury to the human body that has caused the body to go into overdrive, this crazy inflammatory cascade that starts. Now, when the body starts to go into overdrive in inflammation, it causes a bunch of things to also happen on a cellular level within the lungs. And a lot of it happens on the level of the alveoli. So with the inflammatory response, we have the alveoli that becomes super damaged and irritated, and the cells stop functioning as well as they should. So the one thing that ends up getting impacted is going to be the alveolar cells that actually produce surfactant. Now, if it's been a while since you've been involved in respiratory physiology, just to go back to what surfactant does, remember that when it comes to being able to open our lungs and stretch them open, we have surface tension that wants to oppose that wants our balloons to collapse. And it's just like the elastic band that wants to fall in. And what surfactant does is it kind of eases up on that desire to collapse to keep the alveoli a little bit more stable being open so that it's not as hard to open them again. And if we lose that, that's going to make it's so easy for those balloons to fully deflate. And you know as well as I do, when you go to blow up a balloon from fully empty, it is hard. You have to use a lot of pressure for that first little bit. So losing surfactant is probably one of the worst things that can happen to the lungs. So After that, like now surfactant is kind of a problem. Then we're going to have little areas of our alveoli that aren't inflating as easily, and they're going to end up being a little less inflated. And then other things that can happen from that is that because the surface tension of those alveoli are a lot higher than ones that aren't as full, you can think about, again, an elastic band that wants to really collapse again. It doesn't have surfactant to keep it open. They're going to end up collapsing and deflating into alveoli that are more open, that ends up with us losing areas of our lung that aren't going to participate. So now we used to have 5 million alveoli, and now we're down to 2 million, and that's going to keep dropping and dropping and dropping and dropping as we have more and more and more alveoli start to fully collapse and empty into the ones that are more open. So that's going to end up with less area of our lung that can participate in ventilation. Then on the other side, that inflammatory cascade is also going to cause flooding of our alveolar capillary membrane. And this is a huge one that's going to stop our ability to get oxygen across. Remembering from the last episode, we talked about the ability of moving oxygen across a membrane comes down to concentration gradients, but then also that thickness of the membrane. And that thickness of the membrane, if that membrane is all of a sudden getting flooded with more fluid and liquid, it's going to thicken up. And now instead of moving through a thin membrane, we have this thick, juicy membrane we're trying to push through. And that's going to impact the ability of us to get oxygen across. So we have less alveoli involved in gas exchange. And now that membrane itself is now thicker. So we are really kind of hamstrung on two different levels when it comes to being able to clear CO2 and bring oxygen into the human body.
So you talked about surfactant, permeability, the whole inflammatory cascade. How does this translate into the refractory hypoxemia, the stiff lungs, the poor compliance? How does all that evolve?
Yeah, so we've talked already about the loss of surfactant, and that's going to be that instrumental thing in making it harder for us to open the lungs. And that term, that fancy term we use to talk about the lungs being stiff and not opening is loss of compliance. Compliance is how easy we can expand the lungs open. So losing that surfactant and also losing some alveoli that have now fully collapsed is going to decrease the stretch. And a really good idea or a way to think about this is if you have a nice big party balloon, it's easier to blow up than a small water balloon, right? A small water balloon, it's a smaller surface area. And because that has more tension that wants to stay closed, we have to use more pressure, right? And it's that idea that that bigger balloon has more stretch, more rubber that we can actually move open, and it's more compliant. And that is where this idea comes that as we lose alveoli and also have lost surfactant, our lungs don't open and stretch open as easily and become stiff and less compliant. So that's kind of the side of opening the lungs. And then the refractory hypoxemia really does come down to that idea of having trouble getting that oxygen across that membrane, but also recognizing that the inflammatory response and the injury that's happened in the body has kicked up the metabolism within the human body as well. So the human body is running on overdrive, trying to fight the infection or fight whatever's going on and get better. And that means that it's going to be burning more gas, trying to do all these things. It's going to be using up oxygen at a higher rate and also producing more waste products, CO2. So we have a problem getting the oxygen in and also removing CO2 and expanding the lungs already. And now our body's actually using more oxygen and requiring more and creating more CO2 that we're already having trouble getting rid of.
Okay, that is a very good way of putting it. It's like the lungs are already up against a challenge, but then because of the pathophysiology, the body's making even more CO2 and requiring even more oxygen that the sick lungs are having a hard time meeting the demands in that area. I want to go back a little bit to the ARDS-NET trial and criteria that a lot of what we do is based on. It was very focused on tidal volume and PEEP. Can you talk about maybe current recommendations, current literature, maybe what we're moving towards with regards to our focus in managing ARDS patients?
Yeah, so when you've made the decision and a patient that's in ARDS, like they're not going to get better. And usually they're getting worse before they get better. So often we move quite quickly towards intubation and getting them on a mechanical ventilator and recognizing that we're going to try and take over, because this is kind of one of those situations that if a patient is trying to breathe and compensate, they might end up causing injury to themselves because they will, fight tooth and nail to get oxygen in. And now we're dealing with these baby, tiny little lungs that probably aren't going to be able to breathe the same way that the brain is going to want the body to breathe, because the brain doesn't recognize the problems that have happened. So we end up moving quite quickly to take over. So now the patient's intubated and they're mechanically ventilated. And so since 2000, when the ARDS-NET trials the first ARMA trial was completed and done, and then we were getting our ARDS-NET recommendations, the whole goal of ventilation with ARDS ventilation is going to be trying to support CO2 clearance to the degree that we can do without causing additional damage. Because recognizing that if we over-distend or over-pressurize the lungs, we can actually cause a very similar cascade to happen as well, an inflammatory cascade, and cause damage, ventilator-induced lung injury. It ends up presenting very similar to ARDS. So with that, we need to try to do the best we can to clear CO2, but not allow any of that damage to happen. So we have to be very, very careful with how we are ventilating these small, fragile tissue paper lungs that we're dealing with ARDS. And then also using positive end expiratory pressure or extra pressure to try and find a little extra compliance and stretch from our lungs. Trying to think about the physiology of the fact that we have alveoli that are collapsing, and what if we can get them to come back? We can get them to participate in gas exchange again, and we do that with a lot of extra pressure. But all of these things that we're going to be doing of trying to be super, super lung protective with not using high pressures and volumes and using high PEEPs can be very, very uncomfortable. So with that, we usually have to fully take our patient out of it, let them stay completely sedated, decrease that oxygen consumption, often paralyze them for the initial acute phase so that they're not using as much. And then we can fully take over without them kind of interfering with what we're trying to do. So the ARDS-NET criteria really focused around using higher PEEPs and also small tidal volumes in order to try to do this. So small tidal volumes to not over-distend and scar the lungs, and then extra pressure to work on that alveolar capillary membrane and try to, stretch it open and also maybe recruit more alveoli to be participating. And that was what ARDS-NET started with. That's how we've been ventilating now since 2000, so a number of years. But really, mechanical ventilation research didn't just stop there. We didn't just hang our hat up and say, we're done. We hacked the code. We're done. We're never going to make changes again. They're always trying to, move the needle, right? We're always reevaluating and did we get it right? And if you watched or listened to the previous podcast, I talked a lot about how pressure is volume, volume is pressure. And there is this kind of quandary regarding ventilation of what is the problem? Is it volume or is it pressure or is it both or is it the same or what are we actually dealing with? And when we're dealing with tidal volume limitations, which is what the ARMA trial first looked at, realistically, you could look at it from the other side of the coin too, that if we decrease our volumes, what we're doing is we're decreasing the pressures we're applying. And subsequent research has kind of started to go down that rabbit hole and is starting to kind of actually look at maybe it's not really volume. Maybe it's appropriate volume for the amount of stretch that we have within the lungs. And really, it's looking at the amount of pressure that we're applying to the lung itself. And this is this idea of driving pressure, which you may be hearing, if you're walking around an ICU and you're starting to hear the doctors and the RTs talk, then asking about driving pressure. It's essentially the amount of expansion pressure that the alveoli feel during inspiration to open to that volume that we're putting in.
Okay. So the amount of pressure that's needed to initially get that balloon inflated?
Yes.
Or is it different than that?
So it's every single breath. So every time we apply a breath, so we start at PEEP, whatever PEEP we have, and then whatever pressure we push in that makes it to the alveoli to expand that alveoli to the volume that we're delivering every breath, that amount of pressure just in the alveoli is going to be the one that we look at. So if you understand a little bit about ventilation, we essentially want to look not in the airways. We want to take the airways out of it. We want to look at just the lungs themselves. So usually how we do this is when we give a breath, we actually have the patient hold their breath. We do an inspiratory hold. And what that does is there's no flow moving. We pause at the end of inspiration. And since we're not moving flow through airways, then we can read the pressure at the end of inspiration. If you took a big breath in and held it, that pressure in the lung, we read that pressure. And then we look at that difference between that pressure that the lungs are feeling at the end of your breath hold when your lungs are full to when you breathe out before you breathe in again from your PEEP, right? And that's the difference between plateau and PEEP. That's going to give you that change in pressure that your alveoli felt.
Gotcha. Okay. So how are we moving maybe away from just looking at volume to looking at driving pressure? Like, how do you as an RT use that on a daily basis to determine, is my patient getting better? Do I need to tweak the ventilator some more to optimize them? How do you use that in practice?
Yeah, so here's the really interesting link between volume and driving pressure, right? And it really comes back to thinking about an elastic band. So imagine you have a really small elastic band, like one of the micro ones that really only fits over your baby finger. Now, you can't expand that elastic band much at all. You are only able to expand it so much, or else you're going to break it, right? It has a limited amount of stretch. So the amount of stretch that elastic band can do is very different than, one of the big ones that you can get from the grocery store that they put around your strawberries to keep them from falling apart, right? That elastic band is a lot bigger and it can stretch to a larger volume than that small elastic band. And this comes back to the idea of how much compliance you're working with in the lung. How much stretch do you have? And really, it's about fitting your tidal volume to your individual lungs and how much stretch they have. And if you look at that concept of driving pressure that I just talked about, essentially, when it relates to how much compliance. So the volume that you put in the lung divided by the compliance, how much stretch, also is how you calculate driving pressure. So it essentially is a measurement to tell you whether the volume you're delivering is appropriate to the size of lungs that you're ventilating.
Oh, okay. That seems much more specific and effective than just going off of a graph and being like, all right, it's time to go up on the PEEP and it's time to go over on the FiO2. That seems much more precision added to how we manage our patients. I love that. I know that PEEP can be like a controversial topic when it comes to ARDS. How do you think about selecting the right level of PEEP for your patients?
This is a great question because there really isn't an agreed upon method, even with the big brains of ventilation research. So they've looked at many different ways to calculate the perfect, most optimal PEEP. But really, the way I think about it is when I think about the amount of positive and expiratory pressure, like think about you and I walking around. Our lungs magically have this equilibrium point where we stop breathing out naturally, and it really catches us at, and it's a fancy word, but our functional residual capacity, at the point where our lungs will expand nice and easy. But we just talked about ARDS, right? And all of the things that are happening to increase the risk of collapse. So essentially, we can't just use the same number that I would use on you, Sarah, if you were intubated, because your lungs are healthy. They're not going to collapse as easily. So we don't need to put as much artificial pressure in to hold them open the same way that you would do naturally walking around. With ARDS, because they're so prone to collapse, we have to go much higher with that pressure to overcome that collapsible force that wants to happen. So what we need to do with our PEEP is try our best to find that level where our lungs are going to open easier. And that's trying to chase a very specific number for each person. And this is where we get into fancy things, which we won't get into too much specifics about PEEP titrations to try to find PEEP that is going to work the best for our patients. So the ARDS-NET criteria gave us like our PEEP FiO2 tables, and it's a good guideline, but recognizing that that's where you're probably moving towards. But you don't necessarily are going to stay right there. You may end up going up or down a bit depending on the initial mechanics that you're dealing with. So for a patient that is on a ventilator, or if you're putting them on the ventilator, you're probably going to start at 100% FiO2. So the PEEP FiO2 table says that you're going to be anywhere between a PEEP of 16 to 22. Whoa, that's high, right? And remember that FiO2 might come down. So I might start that patient at a PEEP of 10, but then I'll probably actually start to increase it and watch the stretchiness of my lungs. Does my stretchiness go up if I add a bit more PEEP? If it does, that's showing me I'm making a good decision. And then I very quickly can start to titrate and find a good level. But recognizing if my FiO2 is not coming down, then I'm probably going to have to keep going up on that PEEP, just similar to that FiO2 table of where we're going to be in that range.
Hey nurses, I know a lot of you listening work in critical care, the ER, or other acute care settings, places where emergencies can unfold at any moment. And if you've ever wished you felt more equipped to handle those situations, or if you're already experienced but want to take your skills up to the next level, you need to check out the Winter 2026 cohort of Rapid Response Academy. This is a 10-week high-impact training program built for nurses like you. You'll master the science, advanced pathophysiology, critical thinking, evidence-based interventions for shock, sepsis, cardiac arrest, strokes, and respiratory failure. But just as importantly, you'll strengthen the softer skills that make or break you in a crisis, like leading with calm in the chaos and advocating for your patient and navigating those tough conversations with the interdisciplinary team. So whether you're a brand new nurse finding your footing or a seasoned nurse ready to refine your expertise, Rapid Response Academy will give you the confidence and clinical edge to thrive when pressure is the highest. Pre-sales start February 9th, and we kick off our first meetup of our 10-week course Friday, February 20th. To learn more, I put a link in the show notes for you. Okay, back to the episode.
Gotcha. Okay, so can we talk a little bit about proning too? I feel like when in the height of COVID, when you walked to the ICU, like everybody was on their bellies. So I'm glad we're not in that season anymore, but patients still get ARDS, even from non-COVID things. In fact, very often from non-COVID things, it's a trauma patient that develops ARDS or a septic patient develops ARDS. At what point do we go to proning? And what's the big benefit of proning?
Oh, wow. This is a really fun topic because we could talk all day, every day about ARDS net and 6 mils per kilo versus 4 mils per kilo, on all these different, we can go into the minutia of ventilation, but pressure control versus volume control, blah, 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 all these little things. But realistically speaking, there isn't much data for any one thing on whether it actually improves outcomes, except for proning. Proning saves lives. We know this. And, yes, the two-headed dragon that we deal with proning is that it is a lot of physical labor. It is people intensive. It is resource intensive to do the proning and the unproning and, the head turns and all of the things that we have to do. And there are some barriers to the normal nursing care when we have a patient proned, but proning saves lives. So it is the one and only thing when it comes to ARDS. So realistically, any patient that has a PF ratio showing us that it is less than 150, and to back up a little bit, that is looking at how much oxygen we have in the blood divided by how much oxygen we are giving them. And if we have a PaO2 divided by our FiO2, and we get a number that is less than 150, that is telling us that our patient is in severe ARDS and we need to prone. Period. End of story. We need to prone. Any patient that is in that situation, we should be proning because it saves lives. And really, when you think about the why, it makes a lot of sense. And it really comes down to thinking about what our lungs look like in a 3D model. And it isn't like we have these completely uniform, balloons that it doesn't matter which way we're facing or turning, that we're going to have the same size ventilating. When we are applying positive pressure to a lung, air goes path of least resistance, meaning it actually fills more towards the tops of the lungs, whatever is up, whatever the air gets to quick enough, versus our blood flow is more towards the bottom. And then when you think about a patient who's lying on their back in a supine position, we know that the lungs towards the back of the human body is actually way bigger. And it really comes down to the dome shape of your diaphragm. And it kind of dives down more towards the feet, towards the back of the body, meaning that our lungs are much larger towards the back. And they're also wider. Our lungs tend to narrow like a triangle towards the front of our body where our chest is versus our back. It is more like the point of the triangle versus the base of the triangle, which is in the back. So we have almost a 3D triangle towards our chest and also towards our head. So that it's more narrow towards our head and our chest. Did that explain very well, Sarah? Did you follow that?
You actually did a really good job of describing with words for people who are only listening right now and can't see like all of your hand movements. Yeah, I think you nailed it. We have pointy lungs in the front and wider lungs in the back. So therefore, if we can get the widest part of the lungs to get the most oxygenation and perfusion rather, yeah, that's going to be in our patient's best interest. So keep going. You're doing a great job. Keep going.
Okay, so with that idea of the 3D model of the triangle that we're dealing with, and remembering that perfusion is mostly towards the bottom, then when we think about a supine patient, because we have so much lung in the bottom, all of the blood just gets completely pooled on a very thin piece of that base, because look at how big that bottom of the triangle is. And then we have all our ventilation in the top, and there's not a lot of matching. And if you listen to that other episode, that idea of there needs to be money in the bank and someone to take the money out in order to actually get that oxygen to the body, right? We got to have ventilation and perfusion matching. So then we turn our patients upside down. We prone them. We put them face down. So now we have that narrow, tiny part of the triangle in the front. Now, the amount of blood that's spread over a tiny little narrow area of the bottom, if we're putting it to the pointy end of the triangle, it's actually going to fill more of that triangle because it's so narrow in the top. So by nature, we're going to end up getting some of that blood actually hitting areas of the lungs that are getting ventilated because it's able to kind of match a lot better. And we're ventilating way more of the base. We have a lot more surface area that is going to be able to participate in gas exchange because we have so much more lung in the back as well. So just by nature, we end up getting improved VQ mismatch plus less weight on the lungs themselves, pushing back. That abdomen, that chest is now way to the front. There's a lot less body habitus that we have to push and overcome when we turn our patients upside down.
Love it. Yeah, definitely labor intensive, but it is worth it, right? The patient's stats can improve and we can optimize them in that position. It's totally worth it. A lot of the nurses in my ICU wore t-shirts that said, face down, sats up. Definitely COVID times was that t-shirt. Okay, I also want to talk about recruitment. I remember when I first heard this term and I was like, what are they talking about? Can you talk about like de-recruitment that occurs to ARDS and then recruitment that we're trying to do? Like recruitment maneuvers is another term I heard. What are we doing with recruitment maneuvers? What is the patho here? What are we trying to optimize for the patient?
Okay, well, we touched a little bit on the de-recruitment concepts already, like recognizing that we've lost some surfactant, which stabilizes our alveoli open, and then they're more prone to collapse and more prone to collapse into other alveoli. So all of that essentially is leading to that de-recruitment, meaning alveolar collapse. So those little tiny balloons, we have some of them that are collapsing into other ones, and they're not going to reopen when we're applying the same pressure breath to breath. So with ARDS initial research back in the 2000s, they came up with this idea of, well, we know we have areas of de-recruitment and we're using higher PEEPs to try to stabilize them, but what if we gave the lungs a little extra pressure and just held them open, kind of like giving a breath hold to the patients, like big breath in and hold. And like maybe that'll help pop, 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 kind of like popcorn, open up all those alveoli that had collapsed with that nice big breath hold, and then they're going to be open, and then that PEEP we're applying breath to breath is going to stabilize them open, but it kind of gives that a little extra pressure to hold it open. But the hope is without having to go too high with pressures and just holding it open, it's going to not be as damaging. Like, because what the downside of like going too high with our PEEP is that with doing that could potentially, with breaths, be damaging. But a recruitment maneuver is just a static hold. So it's not going to be as damaging. So that was the idea of them. So from 2000 to probably about 2010 to 2012, we were doing recruitment maneuvers quite heavily.
Okay. But then what happened?
So they did more research. And there was, first off, we always have to think about the stress on the heart with high amounts of pressure and holding open, intrathoracic pressure at a high level. I'm sure that every nurse that works in the ICU is thinking one thing right now: oh my goodness, what's the blood pressure, right? As soon as we increase the pressure in the chest, that is going to decrease venous return, and we know that. In our patients that are a little bit preload dependent, it's going to cause massive problems. So with recruitment maneuvers, there were some patients that did not do well. Their blood pressures would tank, and then we're scrambling, trying to undo the thing we were trying to do to get them to oxygenate. So there was that side of things, but also there was a couple studies that showed that recruitment maneuvers actually caused negative outcomes and harm to our patients, and actually, in some cases, worsened situations. So because of that, sustained recruitment maneuvers are no longer recommended with ARDS-NET criteria. Sometimes it's still a rescue thing, but we know that it might damage our hemodynamics. It's not improving morbidity and mortality. And in some cases, sustained recruitments may actually be causing harm to our patients. So because of that, they've said, you know what, we're not going to recommend them regularly. The only thing that it's doing is it's transiently maybe giving us a teensy bump in our saturations, but realistically, there may be better things we can do that we know improve morbidity mortality, aka cough, 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 peroning. So we should be doing that instead, and maybe avoiding these recruitment maneuvers that are not necessarily giving us the bang for our buck that we thought.
Gotcha. Yes, I remember recruitment maneuvers from my CVICU days. They were like, oh man, they're so de-recruited. We need to recruit. And at first I was like, what are we talking about? I know the terminology of recruitment from the military, and I think of the alveoli as soldiers that are being recruited back to war. But you can harmfully recruit people against their will. They're not quite ready, and it can be damaging. So yes, there is recruitment. When we still talk about recruitment, when you talk about recruitment, what is a positive way that you're doing that's safe for the patients? How are you helping to still recruit alveoli without being damaging from these, quote, recruitment maneuvers?
Well, optimal PEEP is a huge one. And we talked about it a little bit earlier of really looking at that PEEP titration to effectively improve compliance, because just like those elastic bands that I've talked about of small ones versus bigger ones, if something is easier to stretch, if you are blindfolded and someone put a small elastic band on your fingers, you can feel with your fingers, it's hard to open. I know this lung is small. I know this elastic band is small. Now, they take it off and they put another one on, and you go to open your fingers and, oh, that's really easy to open. I know that elastic band is bigger. That's the exact same thing that we're doing with PEEP. We are essentially trying to see if we're able to recruit those soldiers to come and participate in ventilation, find those collapsed alveoli to join. And then all of a sudden, if it's easier to stretch open those lungs to the volume that we're putting in, ding, 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 we just answered our question. We know that we just got more stretch, more compliance, more alveoli to the party. We just recruited.
That's good. Okay, let's go back to the interdisciplinary collaboration between nurses and RTs when it comes to managing ARDS patients. Are there any things on the ventilator that you wish nurses looked at more? Things that you would want us to communicate to you whenever they've shifted? I know when the event starts alarming, we're like, RT, we need you in here. But before that, what are the things that you want us to be keeping an eye on? Maybe things that you find nurses don't even know what they are, or they kind of just look past. I know from being a nurse in the CVICU, the focus is often FiO2, what is the rate? And then what is the tidal volume maybe? Not much more than that. What are some of the numbers that you're looking at that you wish we would look at more?
I love this question so much because I think, again, I really am a huge believer in more of an understanding of each other's roles. I think that we become better teammates when we understand more than just the small sphere that we work in.
Yes.
And not necessarily just relying on the person beside us to be the one to fill in the gap. I have worked for a lot of my career to try and expand my knowledge to more than just respiratory therapy. And it has improved me as an RT because now I look at my patients from a more global perspective. And I think same thing for nurses. If they can get uncomfortable and don't be worried about being wrong and stepping into that world, it will make them a better nurse because they'll start to understand so much more about how the tiniest small thing that you do on a regular might be impacting that patient's ventilatory status. And it will improve you as an ICU nurse to huge levels. So with that being said, when you are thinking about a patient, and really it's not just even ARDS, it's any patient in the ICU. If you have a very, very fundamental understanding of pressure control versus volume control, and what is controlled by the ventilator and what is varying based on resistance and compliance or positioning or lung mechanics. Essentially, that is your roadmap to understand whether your patient is getting worse or better. Now, and I will give you a bedside understanding of this. So you have a patient in volume control. So no trick question. What are we controlling in volume control?
How much volume is being delivered?
Exactly. Ding, ding, ding. Now, so when it comes to a closed system, volume is pressure, pressure is volume. Now we are in volume control. So what is not being controlled? That's going to be pressure. Pressure is going to be varying. So if you have a patient who is getting 350 mils for every single tidal volume, and your peak pressures on the ventilator are 26, cool, that's your baseline. But let's say you turn around and you look at your ventilator and you notice that your peak pressures are 28. And then they're 30 a couple minutes later. And then they're 31. And then they're 32. That is a patient that is actively deteriorating in front of your eyes. But you have to remember that nuisance alarms are a thing, right? And sometimes, just like your cardiac monitor, you're not setting your alarms super, super, super tight. So sometimes the RTs will be a little bit wider with their alarms, and they may not have a high pressure alarm until 40. And that patient could be slowly deteriorating and needing more pressure to get the same volume. And now we are applying way too much pressure to that lung if they aren't careful with those alarm limits. So as a nurse at the bedside, you guys know that RTs are many different places. They're not just there. You guys are the first line of defense. You guys are the most important piece to being able to identify patients that are deteriorating quicker than that RT can if they're not at the bedside. So if you're able to understand that, that is so huge.
Okay. So not just looking at what is the rate, what is the oxygen saturation, but what is the pressure? What is the peak pressure? There's so much more to look at, right? At what number would you want the nurse to call you?
Honestly, I would say any trend that is outside of normal. Because if you've been with a rock solid patient, here's a classic call that I get.
Okay.
So a patient that's in volume control, and the nurses call me a lot later, and the pressures are quite high on the vent. The SATs are down, and that's why I was called, because the SATs have dropped. And the patient has no pathology, nothing really going on. And I'm like, the nurse is like, I don't know what's going on. The patient was fine, and now they're not. They're desatting, fix it. So I look, I see high pressures. I'm like, okay, something's changed with my mechanics. Very quickly, I scan, and I noticed that the inline suction catheter was left in the endotracheal tube, increasing resistance dramatically. So what did the vent do in order to achieve that volume? It pushed harder. It pushed harder to get the volume in. And then I just casually asked the nurse, how long ago did you suction the patient? And I find out that it was an hour ago. So then we redo a blood gas. And what does that blood gas look like? Crummy, crummy, crummy. So that patient has not been ventilating as effectively. And that's something that, again, this happens, mistakes happen, but something like this could be very easily either recognized, or even the nurse could troubleshoot. Something's different with my patient. Maybe it's something as simple as I need to reposition them. They've slumped down in the bed and their abdomen's pushing on their lungs. And nurses are more than capable to be able to troubleshoot that issue and be able to fix it, and then just tell the RT. And I'm like, high five, man. You caught that quicker than I would have. It's really unbelievable how quickly and how well RNs can jump in and like recognize those things or be like, oh, this patient has a history of mucus plugs. And all of a sudden I'm noticing that my ventilation is changing. I'm going to give my patient a suction and clear the problem that it probably is. And oh, look at that. They're much better now.
I love it. So I think you mentioned a couple of them, but when you're called to the bedside because something's alarming and it's the pressure alarm, I heard you say, okay, suction, boost them in the bed, make sure the line is clear. Are there any other like troubleshooting things that you're going to be doing that you would recommend us to do as well?
Yeah, like most nurses do this. And again, like I have so much respect for every single nurse that I've worked with. Doesn't matter where they work, on the floors, in emergency department, in ICU. They all are so accomplished in global patient care. Think about the pathology of your patient, of what you're dealing with. And usually that is going to kind of lead you in the right direction. You're going to know the common traps that are going to be pathology induced. And then you have to always think about the equipment side of things. So normally like the acronym that people constantly come back to is DOPES. So displacement of the tube, obstruction, like trust me, the vent's going to be screaming if that's the problem. But like just visually scanning, do you see some type of obstruction or kinking, or is there water or like secretions moving around in the circuit? Like doing that is a kind of a quick thing you can look at. Giving a quick suction to see if you can clear anything that might be down there, and then checking your equipment super quick. Some of those things are really low-hanging fruit that you can do really, really quickly in order to see if there's a problem. But like other than that, go back to pathology. So with your patient, do you have a patient that had like right-sided whiteout and you shifted your patient or turned them in the bed and all of a sudden your SATs are lower? Well, think about it. Did you just impact that VQ matching? Maybe you want to go back. And a lot of nurses probably were like, oh, I would have thought of that 100%. But a newer nurse may have been like, oh, I didn't think about that. But like recognizing those little pitfalls that your individual patient might have are really going to start to lead you down that path. Like if you're dealing with that asthma patient, listen to the lungs. Are you hearing sounds that make you think that they might be constricted? And call the RT, but why not just go ahead and give a couple puffs of the MDI and see if that makes a difference? Like kind of going towards the pathology in that thought process of what could be happening.
Gotcha. Love it. Okay, so DOPE, listen to your patient's lung sounds, reposition in the bed, suction. I love all these things. All right. Are there any common myths or two that you hear with ARDS management that you wish every nurse knew? You hear them talking, strategizing about the patient, and you want to be like, actually, can I just add a little tidbit to that? What would that be?
I think coming back to the idea of sedation and paralysis on the why, because I think like recognizing that, again, it's not about rest. It's about decreasing oxygen consumption and then protecting the patient from themselves. But the second that you no longer need to do that, you are avoiding that. You are taking neuromuscular blockade away or paralysis away, and then you're trying to lighten them. Because as soon as the lungs start to get better, again, if we can get the patient to participate, it's not a bad thing. Now, if the patient is unsafe when they start to participate, we may have to go backwards. But really, just because you're dealing with ARDS does not mean that you need to go to X, Y, or Z. And I'm going to also kind of segue into ARDS-NET protocols of tidal volume targets. Like one of the myths that constantly comes up is hyper low tidal volumes. And some people within their practice may have heard 4 mils per kilo, like using tidal volumes that are lower than the standard 6 to 8 mils per kilo that we normally use. And some practitioners now jump right to 4 mils per kilo. So very tiny baby volume. And when we think about ARDS management, we always have to come back to why we're doing something. And like, there is always a method to the madness of limiting tidal volumes to essentially try to keep that driving pressure low. But really, it comes back to our mechanics themselves and how much stretch we have. We do not go lower unless we need to. And the reason why we don't is because that's going to decrease how effective we're going to be with clearing CO2. And going back to the other episode and that idea of bailing out CO2. And then what are you going to have to do? You're going to have to crank your respiratory rate. But once you get to a certain point, then the wheels are going to start to fall off the bus with being able to actually finish exhaling between breaths. So all this to say that there is this constant trade-off with every single setting that we're going to be adjusting on the vent. That if we go down on something, we have to go up on something else. Or if we are able to go up on something, then we have to change something else as well. And remembering that there is an implication of every single change we make. So just blindly going to the absolute bottom because it seems to be safer is not safer. And you can actually cause trauma with doing that and worsening the situation. So it's about approaching your patient with kid gloves and starting with, 6 mils per kilo-ish, see what your driving pressures are. From that, how much respiratory rate do you need to clear CO2? Are you satisfying those goals of ventilation, which is oxygen in, CO2 out? If you are, that's okay. You don't have to go further. You don't have to drop further. It's not about being as low as you possibly can because it's more protective. No. It's just about avoiding injury.
That's good. It's a very good summary, Melody. Thank you. Final question for you. Can you think about some examples of times when there was really good interdisciplinary collaboration between the bedside nurse and you? Are there certain situations you're like, oh, thank God the nurse grabbed me for that, or that was a really good thing that he or she picked up on, or I love these examples so that I can be that nurse one day to be like, oh yeah, I noticed this thing and I went and grabbed the RT and together we optimized the patient.
Oh, so many things. And I honestly think when it comes to, do you want to stay with ARDS specifically, or do you want to just stay open to everything?
Let's hear it all. Whatever you want to share.
Anytime that a nurse and I are collaborating to lift restrictions from a patient, like taking a patient from sedated and paralyzed, RAS of -5, to getting them breathing spontaneously and mobile and up in a chair and moving and coughing on their own, and anything like that, which is so much collaboration because it involves both people stepping into that, recognizing that it's a lot harder to manage an awake patient and a moving patient than a patient who is sedated and paralyzed. Truly, it is. And committing to doing all that extra work in order to get a patient further along in the process, there is no words for how much that impacts patient care. And thinking about ARDS, any time that we can collaborate and consider proning early, consider some of these interventions that, again, are going to require a lot of hands and a lot of work, taking the time to do some chest physio, and if a patient cannot clear their own secretions, ensuring that pulmonary toileting is done in order to get that stuff out is so huge for our patient. All of that stuff, the implications are so high.
Yeah, love it. I can think of a couple times when the patient was just not doing good. And I called the RT in, and together we're just tweaking this and turning that and repositioning and suction. And within 5 minutes, collectively, we're sweet, we did it. The stats came up, the worker breathing went down, we did it. And you almost want to high five across the bed, yes. Okay, moving on to the next challenge of this critical care day. Yes, I love that. Melody, is there anything else that you want nurses to know about ARDS before we close today? Anything we didn't get to mention today that you feel is important?
I think just focusing on the fact that so much of what we do with ARDS is really about finding the best mechanics we can possibly do, and recognizing that every time our patient is a bit sicker, essentially the whole algorithm, the whole strategy with ARDS is about lowering your expectations. We want SATs of, 94%. Oh, we can't get that. Okay, we're going to go to 92. Oh, we're struggling getting that. Okay, we're going to go to 90. Really, it's about lowering that expectation. Same thing with CO2. We want a normal pH. We're not getting it. Okay, well, let's settle for greater than 7.2. Okay, we can get that. We're doing good. And the same thing with the lung mechanics. We'd love to be 6 to 8 mils per kilo, but we can't do it safely. Okay, let's drop our volumes a little bit more and see if we can manage and limp along with that with our lowered expectations with CO2 clearance. Really, it's about lowering your expectations sometimes in order to stop trauma from happening. And that's really what we're doing. And then trying to steal stretch of our lungs and respiratory mechanics any way we can. And one of the best ways being proning. Proning is going to help with that.
Got it.
So that's really the huge summary that I love to drive home of just there isn't anything fancy more than that. That is the way we approach ARDS. The best we can get with what we were given. And the patient is going to be the way they are. until they get better. So we're just going to work with it and see how far we get.
I love it. I love it, Melody. Well, thank you so much for breaking all this down with such clarity today. ARDS is super complex, but when you understand the physiology, the vent strategies, it kind of starts to feel less like guesswork and more like, okay, we're doing this with precision as much as possible, right? This is super fun. So for everyone listening, if you want a deeper dive into ARDS and ventilator management and rapid response level physiology, I have put all the links in the show notes to all of Melody's social media handles so you can learn more from her big brain. She also has a free ventilator management book that you definitely want to get your hands on. The link is also in the show notes for you. So Melody, thank you so much for your time today. This was a blast to have you back on the show.
Thank you, Sarah. It was so much fun.
Yeah, thank you. So as always, stay curious, stay prepared, and keep bringing calm to the chaos. I'll see you on the next episode.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.